I'm going to spend 20 minutes giving you my thoughts on the current status of COVID and COVID management. I'm going to talk briefly about the impact management of the respiratory infection COVID. Next slide, please. And next slide. So these data are well known to all of you in India and around the world. It is a global pandemic. It has killed almost 5 million people. My country, US, and your country have been particularly hard hit. As you just heard, we are learning how to manage it much better. Next slide. So I want to talk about the respiratory infection. And my first question is going to be, is COVID respiratory infection? Yes. Next slide. So ARDS is not a specific disease, it's a syndrome. And the Berlin definition is it's an acute process. It affects both lungs. It creates hypoxemia, and it is not entirely explained by chronic congestive heart failure. ARDS, as I say, is a syndrome. It has multiple etiologies. It has a broad range of severity. It has different types of pathology. It has different types of trajectory and biomarker profiles. Next slide. So I would like to argue that COVID respiratory failure meets these criteria for ARDS. It is acute, it is bilateral, it is hypoxemic, and it is not congestive heart failure. The etiology is an infection. The severity can be mild, moderate, and severe as graded by the P to F ratio. The pathology is neutrophil exudates that evolve into diffuse alveolar damage and fibrosis. And I would make a comment here that COVID ARDS does seem to last or does have a prominent vascular component to it as well. The trajectory, it can go from days to many weeks, and indeed many patients with COVID respiratory infection can have a very prolonged course, including a very prolonged chronic recovery phase. And the biomarker profiles, there are patterns of both hypo and hyperinflammatory profiles. So COVID meets all the criteria for ARDS, and I think we should think of it as a type of ARDS. Next slide. So let's talk about ventilator management, because that's one of my favorite topics. Let's go, next slide. So the cornerstones of managing ARDS on a ventilator are fairly straightforward. We want to support life. PO2 targets of 55 to 80 millimeters of mercury, pHs in the 7.3 to 7.45 range, although I must emphasize that we can allow permissive hypercapnia to protect the lung as long as hemodynamics of the patient will allow us to do that. We also need to protect the lung. We need to aim at limiting injury, especially in healthier lung regions, and these are typical of all forms of ARDS, including COVID-19 ARDS. The basic rules of managing these patients is we want to limit maximal distension to the physiologic maximum, and that means a plateau pressure less than 30 centimeters of water. We want to limit tidal distension to the physiologic range. By that, I mean tidal volumes of 4 to 8 mLs per kilogram of ideal body weight. And we want to use balanced PEEP and FiO2 to oxygenate the patient while minimizing overdistension and exposure to FiO2. And I have found over the years that the tables that were generated by the ARDS network that are easily accessed on your iPhone by just Googling PEEP-FiO2 tables, these have been very useful in managing ARDS of all types, including COVID. There are two variations of these tables. One is a high PEEP table that is used for sicker patients, and one is a table that uses lower levels of PEEP for patients with better compliance and better P to F ratios. And I really want to emphasize right here that the ARDSNet-based lung protective strategies I've just outlined have an extremely strong evidence base. And we have learned that during the COVID pandemic, using these rules, these strategies have translated into what I think are the best possible ventilator outcomes. Next slide. These are the data from the original ARDS network study emphasizing how useful these strategies are. These are mortality and patients alive and off the ventilator over 180 days following randomization to a protective strategy, the solid upper lines, and versus more conventional strategies which used higher pressures and volumes in the past. The world has adopted these strategies for ARDS, and I really want to emphasize, I think they should be adopted for COVID as well. Next slide. There's been controversy here, however. Two very famous physiologists, clinicians, John Marini and Luciano Gattinoni, have argued that the COVID ARDS pattern has a lot of dead space and often has a lower biomarker inflammatory pattern. And because of that, they've suggested that maybe we could use higher tidal volumes and lower PEEP. Unfortunately, they don't offer any real clinical data to support these strategies, but argue from a physiologic rationale. I know John Marini and Luciano Gattinoni very well. They're friends, and I really respect them. But I'm afraid at the moment, the clinical evidence base, to me, suggests that we should be sticking with what we know works well in ARDS, standard lung protective strategies. Next slide. And one of the reasons I say that is because these data are from the original ARDS network study back in 2000. And what I want you to look at is that the healthiest members of this study population, the ones with the best compliance and the lowest inflammatory state, the ones on the far left, even they benefited from a lower tidal volume lung protective strategy. So just because we have a lower inflammatory pattern and just because the patients don't look healthier patients, and it works for the sicker patients. And again, should be used, in my opinion, for all those with COVID ARDS. Next slide. Summarized nicely in an editorial from Todd Rice that was published a little over a year ago, where he was arguing that social media and other authorities in the field were arguing that we needed novel music respirator. And Todd wanted to emphasize, just like I'm trying to emphasize, that calling for paradigm shifts is really unfounded. And he has a classic quote here that I'll summarize: abandonment of evidence-based principles is clearly unacceptable at this time. And I think Dr. Rice is exactly right. Next slide. So ventilator management, again, is straightforward. In my opinion, we follow the standard lung protective strategies that we've been using successfully for the last 20 years. The one additional comment I'd make, I don't have a slide on this, is that another parameter we've been looking at very carefully to help us in lung protection is a parameter called the driving pressure, the plateau pressure minus the PEEP. And in addition to keeping the tidal volume, plateau pressure, and PEEP evidence-based, I think there's growing evidence that keeping this driving pressure less than 15 may also help. There's more to managing COVID than ventilators. Pharmacologic management. I know you're going to hear other talks on this during this symposium, so I will be very brief here and review the three basic medical approaches we use in the United States, approaches that have been approved by the United States Food and Drug Administration. Next slide. The first of these is the use of monoclonal antibodies early in ambulatory COVID. There are several studies, a couple of them summarized here, that emphasize that giving monoclonal antibodies to early, not so very sick ambulatory COVID patients can actually reduce progression of disease. And that's one of the medications we use in the United States, approved by our Food and Drug Administration. Next slide. The other drug that I know you all are familiar with is remdesivir. This is also approved in the United States. It has been well studied in large studies, the biggest one published last year in the New England Journal of Medicine. Next slide. And the data here, I think, are pretty convincing. The overall study, summarized in the upper left panel, shows that remdesivir proportion recovered was significantly better. And what's interesting is the circled graph on the lower left, which emphasized that this was particularly important in patients who were sick enough to require oxygen. If they were not sick enough to require oxygen, this drug did not seem to help as much. Next slide. And dexamethasone. This is a potent corticosteroid with predominant glucocorticoid activity, and this too was studied very extensively. The largest study, again, published in the New England Journal of Medicine in 2020 with 11,000 patients. Next slide. And again, I want to emphasize the overall effect looked good. This is mortality being plotted over time. But I want to emphasize, again, the circled graphic in the upper right to illustrate that, in fact, it had its most prominent effect in patients who went on to require mechanical ventilation. So the bottom line, dexamethasone reduces mortality in hospitalized patients requiring mechanical ventilation. Next slide. Although this is not specific to COVID, I would like to point out a fourth medication that we use, that is anticoagulation. I mentioned earlier there does seem to be a predominant vascular involvement in COVID ARDS. And we learned some time ago that anticoagulating people with COVID did improve outcomes. It lowered the admissions with respiratory failure, as illustrated on the right. Fortunately, bleeding complications were very low. There was a controversy right from the start, however, about whether this should be full dose anticoagulation or more traditional so-called prophylactic anticoagulation. Next slide. And this study just came out recently. Intermediate versus standard dosing of enoxaparin. Next slide. And I think the results speak for themselves. There really wasn't much benefit here in terms of higher dose enoxaparin in these patients with COVID respiratory failure. So the bottom line here is that intermediate anticoagulation is adequate for most patients with COVID respiratory failure. Next slide. So let me spend a couple of minutes on some of the other support strategies that we use in the ICU, along with our ventilators and our medications. Next slide. I want to touch on four briefly: the high flow nasal cannula, the prone positioning, the use of neuromuscular blockade, and finally, ECMO. Next slide. The high flow nasal cannula has been a particularly useful modality. It's different from a traditional nasal oxygen in that the flows can be very, very high, 60, and some newer devices actually go up to 80 liters a minute. And it does two very important things besides just supply oxygen. Number one, it creates a washout of all the upper airway dead space, the nasal pharynx, and makes ventilation more efficient. And the second thing it does is it gives a small amount of CPAP on the order of 3 to 7 centimeters of water. Next slide. This is an older study in other forms of ARDS that illustrates that using the high flow nasal cannula instead of standard oxygen or non-invasive ventilation actually had a mortality benefit. This is other forms of ARDS. Next slide. And patients who were particularly hypoxemic, this really had a dramatic effect on lowering the need for intubation. And that's why it probably improved ultimate outcomes. It kept patients off the ventilators, complications of ventilators, and improved outcomes as a consequence. High flow nasal cannula is a mainstay of therapy at my institution. Next slide. And more recently, HFNC, high flow nasal cannula, has been studied in COVID. And I've outlined the important outcomes here, showing that the need for mechanical ventilation and mortality are improved by the use of the high flow nasal cannula to avoid intubations. Next slide. In fact, it's now a standard recommendation by a number of authoritative bodies. High flow nasal cannula is recommended, suggested, and this is a superior device to use over non-invasive ventilation. In fact, in my institution, if you fail high flow nasal cannula, if you're not doing well with the high flow nasal cannula, you do not go to non-invasive ventilation, you go on to intubation. And one of the scores we've been very interested in is called the ROC score, which is basically the P to F ratio over the FiO2, or excuse me, over the respiratory rate. And there are tables that you can Google that give you an idea of the probability of the need for intubation. And we couple that ROX index with high flow nasal cannula as a way of trying to avoid intubations, and then using intubations when they really are needed. Don't delay intubation when it's needed. Next slide. Prone positioning. This has become a standard of care. Next slide. Prone positioning has very sound physiology. You get much more air-weighted lung. The heart is now not resting on the left lower lobe. Gas exchange is better. And in ARDS, going to the prone position in patients with low P to F ratios, next slide, does improve outcomes, including mortality. This is the study published in the New England Journal several years ago. What's important is that this same effect is being seen in COVID ARDS. Next slide. Prone positioning has become a standard of care. You can even do it in non-intubated patients. This is being tried more and more as a way of trying to improve oxygenation and hopefully avoiding intubation. Some people respond very, very nicely to this, and these are non-intubated patients, and we are using this in an increasing fashion in my own institution. Next slide. Neuromuscular blockade is controversial. It's a two-edged sword. Next slide. This is an older study suggesting that the use of early neuromuscular blockade in severe ARDS actually improves outcome. Subsequent studies have not been able to see such a dramatic effect. Nevertheless, it does have clinical benefits, and I think is worthwhile using in early ARDS to get patients on the who have just been intubated on the ventilator. Next slide. It does reduce oxygen consumption, it improves dyssynchrony, and it limits tidal volumes. The downside is disuse atrophy, which can increase and accentuate critical care myopathy and post-ICU weakness. Next slide. In practice, as I say, with conflicting clinical trials, my own advice is to use it early until the patient is more stable. And again, you may not total paralysis, or muscular blockade, I should say, to reduce oxygen consumption and ventilator Next slide. This is a technology that is not widely available, but it's a very simple form of extracorporeal membrane oxygenation, veno-venous, where you take a catheter and drain as much as 70% of the cardiac output from the venous system into a membrane oxygenator and return it to the right atrium and right ventricle for delivery into the lungs, where the lungs can add to the oxygenation. It is really good at getting CO2 removal accomplished. Oxygenation is not 100%. The lungs still need to contribute to the oxygenation process. A problem with it that is still can be challenging is the need for anticoagulation. Next slide. This is to show you that in traditional or other forms of ARDS, severe ARDS, there is a trend for mortality benefit in using ECMO. If you look at hypoxia, this difference becomes more significant. Next slide. We use ECMO at Duke in the patients who are failing conventional ventilation with standard lung protective strategies and who do not have more than one organ failure. Next slide, please. So in other words, if you have multi-organ failure, ECMO is not offered to patients. I need to go on to my final couple of slides here, please. Yeah, there we go. That's just showing you, if you look at different ways of looking at these data, the ECMO group does reach statistical significance. Next slide, please. So I want to conclude by just looking briefly at outcomes. Next slide. This is a very nice review in Critical Care Medicine, just published a few months ago, showing the effects of age and showing the effects of the need for mechanical ventilation, the need for mechanical ventilation and vasopressors, the need for all three, and the use of ECMO on mortality. As you can see, age does have an effect, and not surprisingly, the more organ failures you have, and the more needs for invasive support therapies, the more your mortality is increased. Next slide. So let me summarize and conclude. Not something you all know already. COVID is a huge global issue, almost 5 million dead so far. It is ARDS. Ventilator management should use standard lung protective strategies. In the US, we have approved medications that are standard of therapy now. Other support strategies that I think have roles are the high flow cannula, prone positioning, neuromuscular blockade, and if you have an ECMO center, for those patients who do not have multi-organ failure, but who are failing lung protective strategies, are candidates. And again, not surprisingly, outcomes are related to severity, age, and other organ failures.